I'd like to take this opportunity to welcome all of our listeners today, wherever you might be in the world, to the IFOMPT webinar and lecture series. My name is Paulo Sanzo, and I'm a member of the IFOMPT Executive Committee and from Canada, and I will be acting as your moderator today. I hope that the lecture that you're about to hear over the next hour gives you some time to get away from some of the challenges that we're currently experiencing around the world. IFOMPT represents manipulative physical therapists around the world and attempts to set up educational and clinical standards that are driven by the available scientific and clinical evidence. We hope that the webinar that you're about to hear will assist with providing some valuable information from a renowned and well-respected speaker. Just a reminder that as the moderator, I will be able to ask any questions to our speaker. Questions can be typed into the chat bar, and then I will ask these questions at the end of the presentation. It is my great pleasure to introduce to you Dr. Kim Bennell, and the title of her presentation today is going to be called Increasing Accessibility to Physical Therapy for Knee Osteoarthritis, a very timely topic in the current situation. Kim Bennell is a Redmond Berry Distinguished Professor, Dame Kate Campbell Fellow, an NHMRC investigator in the Department of Physiotherapy at the University of Melbourne. She leads the Center for Excellence, Exercise and Sports Medicine, and the NHMRC Center of Research Excellence in Translational Research in Musculoskeletal Pain. She is also a Fellow of the Australian Academy of Health and Medical Sciences. Her research focuses on non-drug, non-surgical management of hip and knee osteoarthritis, as well as ways to address evidence practice gaps around uptake of pain management and lifestyle interventions by clinicians and patients. She has a special interest in telehealth interventions. Kim has over 400 peer-reviewed publications, including clinical trials published in JAMA, the Annals of Internal Medicine, and BMJ. Kim was on the board of the Osteoarthritis Research Society International from 2008 to 2019 and currently chairs its rehabilitation discussion group. It is my great pleasure to introduce Dr. Kim Bennell.
Thanks very much, Paulo, and welcome everybody from wherever you may be in the world. Thank you for giving up your time today to attend this webinar, and thank you to IFOMPT for inviting me to speak. And when I was asked for my topic, I did this way before the COVID pandemic. I thought I would talk about telehealth in relation to knee osteoarthritis and some of the research that we've been doing. And as Paulo mentioned, it then turned out to be very fortuitous because the topic, I suppose, has even more relevance now in this pandemic. And in Australia, telehealth for physiotherapy hasn't been funded by our government or our health insurers. And there'd been a lot of lobbying going on to try and make that happen, but they hadn't been forthcoming. But then during the COVID-19 pandemic, they have now given temporary rebates for telehealth for physiotherapy. And so now all of the physiotherapists, particularly in private practice and public hospitals, have been scrambling to deliver their services via telehealth. So hopefully you will get something out of tonight. And as I said, I'm going to go through some of the evidence that we have as it relates to knee osteoarthritis. So what I'm going to talk about is just a little bit about knee osteoarthritis and the type of treatments. Most of you will be familiar with how to manage knee osteoarthritis, so I'm not going to spend a lot of time on that. Look at what are the different online e-health, telehealth, or different names for similar things, approaches that we have. What do patients and clinicians think about it? Are these approaches effective? Do we have evidence to support what we do? And what are some of the implementation issues that are relevant? So knee osteoarthritis and its treatment. We know that it's a chronic joint condition and has no cure. And as such, self-management is a key part of its management. We know that people generally present to us because of pain, impaired function. They also have poor quality of life. And clinical guidelines really recommend non-pharmacological management as the first line treatment, so that everybody with knee osteoarthritis should be receiving non-pharmacological management before they go on to drug therapies in combination, and certainly before they trial surgery such as total joint replacement. And there is evidence practice gaps where we know that this is what people should be having, but instead they're having surgery where they haven't even given non-drug management a good go. So that's what our clinical guidelines say, and they're really consistent around the world. As I mentioned, self-management approaches really are the key, and the clinical guidelines are really consistent in recommending that everybody with knee osteoarthritis should have some education, whether it be verbal or written, but they should be educated about the disease and about the different treatment options. They should have exercise and physical activity, and that's irrespective of how severe the joint looks like on x-ray, how much pain the person has, how old they are, how many comorbidities they have. Exercise and physical activity is a core component for all people. For people who are overweight or obese, weight loss is important. And then pain management strategies, teaching the patient ways in which they can manage their pain, because as we've said, there's no cure. So all of these self-management approaches really are amenable to being delivered remotely via different telehealth technologies that we have. Because if you look here, I haven't got manual therapy up here, and that's because manual therapy in most of the clinical guidelines is either not recommended for the management of knee osteoarthritis, or if it is recommended, it's recommended conditionally, meaning not for everybody. For some people, it might be useful, and it's only to be used for a short-term treatment, and as I said, and not for everybody. So manual therapy really takes a bit of a back seat when you look at what we should be doing to manage patients with knee osteoarthritis. So what are some of the online e-health/telehealth approaches that we have? And as I said, they're just different names. People use different terminologies around the world to describe similar things. So we can use telephone and SMS. There's video consultations, and that's a lot of what people have now been doing to deliver their care during this pandemic, have been using video consultations such as using Zoom or Skype or special platforms that are out there for video conferencing. Websites, a whole range of apps are out there. And all of these different approaches, they can either be automated, self-directed, where there is no therapist input whatsoever. The patient can work through them themselves, or they're fully automated, or they can involve therapist involvement, and that involvement can either be real time, like we're doing here, or video conferencing where you're speaking to someone, or it can be asynchronous. For example, you might type in a question and then the therapist gets back to you later with the response. So the involvement of the therapist is not happening in real time. Or there's descriptions of interventions that what we call blended interventions, where there is some aspect of therapist involvement with some aspects that are automated, or there are some aspects that are face-to-face, traditional physiotherapy with some of these telehealth approaches as well. So there's a whole range of permutations and combinations with the approaches that are out there and described in the literature that are being used. So why would we use these approaches? What are some of the advantages? Well, I think one of the key advantages is geography, and Australia is a very big country, like many other countries, where there's a lot of people that live in very rural or remote areas where they just do not have access to visit physiotherapists. So, this allows them to have access to therapists which they normally wouldn't be able to do. So geography is a key part. Mobility issues. So people, even if they do live in a major city where there are physiotherapists that they could see, they can have mobility issues. They may not be able to get public transport. They may not be able to drive themselves. So getting to visit someone face to face can be difficult because of their mobility issues. again, convenience. So even if, again, you live in a major city, it's quite inconvenient to get out there in the traffic. You have to go to the place, park, find parking, costs money. And so the convenience of being able to do it from your own home, excuse me, remotely is very valuable. And then we had this escalating prevalence of knee osteoarthritis. So we know that the prevalence is just increasing because the population is getting older. There are increased rates of obesity, and all of those contribute to an increased risk of developing knee osteoarthritis. And our public health systems, or our health systems around the world, it's the same here in Australia, but the same elsewhere, are just not going to cope with being able to treat all of these patients. And so we need to come up with some innovative health service delivery models that are more cost effective, that can reach more people. And so that's a real key driver as well. And then I added this because obviously this is a key factor, that we don't know what's going to happen. And when we find ourselves in lockdown, we're in lockdown here and many countries are in lockdown, where you're not able to go and visit a physiotherapist face-to-face because of the risk. And so this COVID-19 has really highlighted, I suppose, the real need to be able to deliver our services remotely. So what do patients think about such services? And this, our PhD student, who's now our postdoc, but Belinda Lawford, did some work in this area. She did a large survey of patients with hip and knee osteoarthritis in Australia, had 330 people who lived in metropolitan region and rural Australia, and they completed a survey about their perceptions of and their willingness to use remotely delivered service models. So she was interested in telephone and interested in video conferencing. And she asked them to rate their agreement to a series of statements about various aspects of telerehabilitation. And the majority agreed that these services would save them time. They felt that they would be easy to use. They did feel that they were able to have their privacy maintained. But there was no consensus agreement, so a little bit of disagreement, if you like, some people agreeing and others not agreeing, that about whether the lack of physical contact would be an issue. Would they be willing to pay for it the same as they would face-to-face? They were, again, whether phone delivered exercise would be effective, they weren't really sure. And they weren't really sure about whether therapists could adequately monitor them over the phone in particular, where they weren't being seen. So what did physiotherapists think? So she also did a separate survey in 217 Australian physiotherapists to get their perceptions of the telephone and internet video service models for delivering exercise, in particular for the management of osteoarthritis. And again, most of them agreed that both the telephone and video conferencing would save the patients time and maintain their privacy, just as the patients had thought. And again, a bit like the patients, they were, they had some concerns about this lack of physical contact when consulting via the telephone or the video, and they favoured the video technologies rather than the telephone to deliver care, which, as you can imagine, you can see someone, so you're getting more feedback. And I think, again, this reflects that we as physiotherapists, we're a hands-on profession, and so hands-on is important, and it's hard for people to imagine how this might be able to, how can we adequately treat someone if we can't touch them and show them what to do without, with the touch, and manage them with touch or manual therapy. So then that's what people thought, and many of those people thought those things, but they hadn't actually ever used teleconferencing, neither had the patients. So what is the evidence around how effective are these approaches for the management of osteoarthritis? This was a systematic review and meta-analysis that was done by Trevor Russell's group in Queensland, and they looked at real-time telerehabilitation for musculoskeletal conditions as a whole, but many of the studies they found were in relation particularly to rehabilitation after joint replacement surgery. They found 13 studies that met their eligibility criteria, and they looked at whether these telerehabilitation could be effective in improving physical function and also pain compared with how you would normally be treated for these conditions. Now, this is a forest plot. If people aren't familiar with forest plot, the black diamond is the average of the study results of the different studies. You can see here there were 6 studies that looked at the effects for pain. You can see the results of individual studies, and then the vertical line at 0. If the diamond crosses 0, that means that there was no difference between the 2 conditions. So in this case, what you can see is that real-time telerehabilitation was not different from usual care for the management of pain in musculoskeletal conditions. And if we look at physical function here, again, you can see there was 7 or so studies that looked at the outcome of physical function. And you can see that the black diamond there doesn't cross 0. And so what that's saying is that there were significantly greater benefits for physical function using telerehabilitation than usual care. So that's very interesting, showing that either it's similar to or even greater benefits from telerehabilitation compared to the usual way in which it's managed. And as I said, several of these studies related to total joint replacement. Our work, led by Rana Hinman, my colleague, Professor Rana Hinman in our group, and look particularly at telephone delivered exercise. And you can imagine, so when we asked the patients, do you think that you'd be able to have telephone delivered exercise? Would that work? So we wanted to test that. And what she did was to take a existing musculoskeletal helpline that was run by one of our arthritis foundations. And so that service was where you ring up and you get a nurse and you speak to the nurse and they give you some advice on the telephone. And so what she did was embedded a telephone delivered service with physiotherapists to this musculoskeletal helpline with the nurses. And so people randomised with knee osteoarthritis into that group received as well 5 to 10 telephone consultations with one of 8 physiotherapists over 6 months. And the physiotherapist had to prescribe a muscle strengthening exercise program for the patient and a personalised physical activity plan. They were given, provided with some educational resources and some exercise tools, so they were sent some resistance band. And we also trained the physiotherapists in behaviour change support, because we really felt that when you're delivering care in this manner, there's a really big emphasis on the way that you communicate with patients. And so we felt it was important to train the physio specifically, and so to use a person-centred approach to build the physio's confidence, their knowledge and motivation, so that they could then impart that to the patients. And that was just published in British Journal of Sports Medicine this year. And what she found was that at 6 months, there was a significantly greater improvement in function, but not pain at that time point. Although a large number of the secondary outcomes that we measured did show improvements compared to the control group. So they were able to deliver care in this manner. But what was really interesting is that Belinda Lawford, our postdoc, also did some qualitative studies where she spoke to a subgroup of patients about this telephone delivered service, and she also spoke to the physiotherapists. And you can see by the title of the patient one there, I was really sceptical, but it worked really well. And this is really what we found, is that in the beginning, patients were very sceptical about, how on earth is the physio going to be able to prescribe me a program of exercise over the telephone? But in actual fact, they really described mostly very positive experiences and really valued the convenience, the accessibility. They felt that they were able to perform their exercise program without supervision. They saw benefits as well. So they really, really show that a service was broadly acceptable to consumers, although many of them did say, look, it'd be good to have perhaps one visit to the physiotherapist, because they didn't really know who they were talking to. They hadn't seen the person before, so it was just this random person on the phone. In terms of what the physiotherapist said, again, the title that we named it, I was really pleasantly surprised. So again, same sort of thing, where prior to delivering the intervention, the physiotherapist really felt that the telephone should only be used for follow-up, and it really shouldn't be the primary mode of providing care. But they felt that this lack of visual and physical contact with the patients would be quite problematic. But after they delivered the intervention, they really reflected that it exceeded their expectation, and that they did see that the patients had these really positive outcomes. They found that this focus on communication and having to really listen to the patient, and that allowed much more personal communications with the patients, shifted the patient's expectations away from passive hands-on therapy, because the patient knew that they weren't going to be getting passive treatment. They knew that they were going to have to be the driver of the care, that they were going to be having to self-manage. So it really did shift patient expectation as well. Another study that we did, this one was looking at the effectiveness of a remotely delivered service that involved two aspects. One was the therapist prescribing a home exercise program, and we used Skype at that time. So this was real-time video conferencing, one-on-one. And patients also had to do an online automated pain coping skills training. The exercise intervention, the physiotherapist gave 7 video consultations via Skype over the 3 months. And again, they prescribed a structured strengthening program of around 5 to 6 exercises. They were able to demonstrate them for the patient and observe the patient doing the exercises. We supplied the patient with some TheraBand, ankle weights, and there was some assistance from researchers to set up Skype if patients hadn't been used to using Skype before. The pain coping skills training intervention is a cognitive behavioural therapy program, for teaching the patient skills that they can use to manage their pain. It was developed by Professor Frank Keefe, who was a psychologist over at Duke University in the States. And it was originally developed for chronic pain, but it was done by psychologists face-to-face. And they took the program and they put it online, and they made it into a self-directed program, interactive, but the patient could work through it on their own. 8 lots of 45-minute weekly module to teach the patient things such as progressive muscle relaxation, about activity rest cycling, coping thoughts, problem solving, pleasant imagery, and so forth. And so the results of our randomised controlled trial in over, I think it was around 130 patients or so, you can see here that the intervention group had significantly greater improvements in pain and function at the 3-month time point immediately after intervention, which was sustained over the 9 months, compared to the control group who received online education and information alone. We also did, again, some more qualitative studies to look at what both the patients and physiotherapists thought about this. And what we found was that the main themes that came out from this qualitative research was that people did find the technology easy to use, even if they'd never used Zoom before, Skype before. It was of sometimes variable quality depending on people's setups, bandwidths and so forth, and people did find having some setup assistance helpful. They found it was very convenient, very time efficient, it was very flexible, and it did increase their access. And you can see here some of the quotes from the patients and the physios. So one person said, "I found it really easy. I hadn't done it before. It was really, really good." Another one particular participant was away on camp and Skyped from their tent. Someone said one of the patients sort of had a dodgy internet connection, So they sort of glitched up every now and again. We can all relate to that. And someone said, one of the physios, you could see the patient clearly, you could see them moving around clearly, you could hear them clearly. Some of the other things that came out was around the fact that it really empowered the patient to self-manage because they were doing it in their own home environment. They could, they could show them the steps and perform the exercise on the steps. Again, this focus on effective treatment elements rather than hands-on, as I mentioned before. And again, something that physios can bring up as a reason not to do it is that, oh, but if I can't see the person face to face, it's going to affect the therapeutic relationship and my patient rapport. But that wasn't the case at all. There were very positive therapeutic relationships. Patients really valued that personal, undivided attention with the physiotherapist. They found it was very supportive and friendly, and again, increased their access. So again, here someone said, I was at home, I could relax, I could feel okay about what I was doing, and I didn't feel intimidated at all. Where going to some place with the gym and other patients can make people feel intimidated. Again, someone said, one of the patients, this sounds a bit crazy, but it was almost more personal than in the past. The therapist was coming to you, so it really shifted that power dynamic. It was you coming to the patient rather than the other way around. And again, one of the physios said there wasn't any option of getting bogged down with hands-on stuff that wasn't going to ultimately be what they needed to manage. So they used their time more profitably to be able to help empower the person to self-manage. The therapist did, again, when you're trying to change how therapists normally do something, it does take people time to adjust their routine treatment, and some people said about having to modify their usual habits. Some people still did find a bit of discomfort without having to put their hands on, and they felt safe because there was this research environment safety net. And again here, some of the quotes from the physios. I was pretty skeptical at the start. I thought, I'm going in half blind here. I want to get my hands on these knees. But actually, I got over that. I'm quite comfortable that I'm not missing too much at all. And now I'm thinking, you know what? Maybe all that doesn't matter. Someone said, required them to give me a lot more input. It will eliminate some of my normal go-to tactics. And someone else, I found myself really reflecting on the language and the cues that I was telling the patient to use. And then someone else said, you're kind of limited with assessing ADL stuff. A lot of it came down to the subjective. But generally, as I said, very positive experiences. We're currently testing this. We conducted a pilot study and found it was very acceptable and very feasible. In our previous trial, it was one patient to one physio. But now what we're testing is a group program where there's one physiotherapist and we're using Zoom, and we have a number of patients online at the same time to go through an exercise program, and they work through with a website. And so we tested two groups, one a group of 4 and one a group of 8. And we found that the group of 8 patients actually worked better, which we were surprised about. We thought that might be too many, but it actually worked better because there was more input and different people could have a say and others could rest, whereas when it was just a more limited number, you felt like you had to go around to each person. So it really worked better with a greater number. And I think obviously this is going to be more cost effective because here you're treating 8 people at the same time, so it can be much more cost effective. So we're going to now conduct a bigger trial to test this. Now that was video conferencing, but there are other out there in the literature, web-based automated programs. So these ones are no therapist input at all. And this was a program that was developed over in the Netherlands called the Join to Move. It was a 9-week program, and the aim was to increase overall physical activity levels rather than structured strengthening exercise like we'd been doing. It was to get the person to increase their physical activity levels. So they used behavioural graded activity approach where the person had to choose their own activity and then set themselves some goals and increase over time with that. And as I said, it was totally automated, no input from a therapist. And what they found was that patients did have improved function at 3 months compared to a waitlist control group, but not at 12 months. but they did have improved physical activity levels at 12 months, but not at 3 months. So they probably did learn some strategies to help them increase their physical activity over the time. But a problem with the automated programs is that adherence can be an issue. And here in the graph here, you can see the different modules. These are the 9 weekly modules, so once a week for 9 weeks. And you can see the percentage of people who are continuing with the module, have started the module, or have discontinued or skipped the module, and then the ones who have discontinued. And you can see that about 20% of people discontinued from first week. They stopped the program after the first week. And then that number, or that percentage, increases over time, so that by week 9, you can see that more than half the people have discontinued the program. So, we need to, if we're using these automated programs, see if we can come up with ways to help increase adherence to the programs. So you might recommend them to your patients, and then maybe you could check in and see how they're going with them. So there might be some input as well to help with that. And what the researchers then also tested was, well, we've got this nice automated program. Why don't we see if we can blend it with some face-to-face input, so that there is some therapist input as well? Maybe that will be better if there's some therapist input. So what they did in this study was they had 2 groups in their randomised controlled trial. One group got the blended intervention and one group got the usual physiotherapy. And you can see that the blended intervention comprised 5 physiotherapy visits plus this web-based program, whereas the usual physiotherapy program involved a mean of 12 visits. So some people were getting 18 visits or more. So the mean was 12, some were getting less. So it's obviously going to be much cheaper for the blended intervention than the usual physiotherapy. And you can see the results here. This is for physical function. There's actually no difference between the usual physiotherapy and the e-exercise or the blended intervention. So both groups showed improvements over time in physical function, but you can see that the blended intervention is obviously going to be cheaper because it involved less physio visits. They also did a qualitative study where they wanted to look at the physiotherapist's experiences. And what they did was they said, look, they let them use it for the 12 weeks, and then they said, well, look, you're free to now keep on using it with your patients, not in a trial anymore. Use it with all your patients and see how you go. And what they did was to then have a look at how many were using it and what was people's experiences. So what they found was that the physios again had mixed experiences with it. And out of the 123 physios, only 10 of them, so 11%, continued to use this web-based application after the study period. So they wanted to look at, well, why weren't they using it? It seemed to be effective, or equally as effective as the usual physio. Why weren't people using it? Interestingly, 22% said it was a major disadvantage because it resulted in less income. So you can see when we're having private practitioners who have to, they're running a business as well, that can be a driver of the type of care that therapists may be giving, and so they felt that it took away from their income. Others said that they didn't think it was appropriate. They preferred to sort of be doing their own treatment and not sort of be guided by this and having to incorporate this web-based application. Others said it required time to have to show the patient what to do and talk about it. Others were sort of felt that their professional autonomy was being challenged, that I should be able to do what I want and I don't want to have to do this. And so there's a whole range of reasons that get in the way of implementation, and so different barriers. You can have something that might be effective, but what are the barriers to then getting it implemented into usual care? There is another blended intervention for knee osteoarthritis that's out there. It's called Joint Academy, and this is from Leif Dahlberg and their group in I think they're in Sweden or one of the Scandinavian countries up there. It might be Denmark. But they have got a digital platform, and on this digital platform they've got a lot of educational material, they've got a lot of exercise and videos and so forth, they've got a lot of weight management resources, so a lot of information to help the patient self-manage. And then what you can get is support from a physiotherapist, but rather than it being real-time or synchronous, it's via this asynchronous chat function. So the patients can get access to this digital platform, and then they can post a question to the physiotherapist and have it answered at some stage. And patients have to pay to go on and use this service. So this is a pay service. And they haven't yet done any randomised controlled trial on it. The only research at the moment that they have is a longitudinal cohort study. So obviously in this one, what you do is you just take people that have come on board and then you measure them at different time points. And you're not doing a randomised controlled trial, which means that you don't have a control group and you don't know whether the people that stopped using the platform, who may not have been benefiting at all, you're not measuring those people. So it can bias the results and make it more effective than you might find when you do a randomised controlled trial. So nonetheless, though, they've conducted this cohort study from their register, and they looked at people over 48 weeks, people who had used it over that time period. And what they did find, that there was some improvements in pain and function that were sort of clinically relevant over time. But as we said, the lack of control group and randomisation mean that you can't fully conclude that it's more effective than sort of not using this platform. But nonetheless, they're the examples of some blended interventions that are out there, and this is certainly commercially available and out there at the moment. So what are some of the implementation issues? Well, the first thing is evidence. We need evidence, and one of the reasons that our private health insurers hadn't been funding tele-rehab up to this point before we had COVID was that they said, well, what's the evidence to support it? So we do have some evidence, but as you can see in osteoarthritis, there's not mountains of evidence, but there certainly is evidence to show that it is effective, but we need more evidence to look at different modes of delivery of sort of telehealth. So that's one of the issues. We need some evidence to show that it's effective. The next implementation issue is that it does require a different therapist skill set. So you do need some training in how to do it, and I think that's been some of the issues again with COVID, is that people have had to, or physios have had to rapidly transform their physio practice from a face-to-face service to an online, remotely delivered service, and that they haven't had the time to have the training. They've not necessarily had the confidence or necessarily the experience or the skills to do it. So we do need to ensure that there is training, so that, and included in our undergraduate training or our training of physios, we should be training them for the future and training them in how to deliver telehealth as well, not just hands-on. Acceptability. It's only going to be uptaken if it's acceptable by patients and clinicians. And certainly what you find is that once people have experienced it, they certainly find that it's very acceptable and they really value it. But if they haven't experienced it, then they can, they still have some ambivalence perhaps to whether it's going to be effective. So it needs to be a marketing campaign around the benefits of and the convenience, the effectiveness. We need to have this marketing campaign, not just for patients, but also for clinicians as well. Because as I said, many of the clinicians were skeptical initially, and it was only after they delivered it that they went, yes, this is really good. Safety, we need to know which patients should we include. And again, that was a big question that the Australian Physiotherapy Association was being asked by the health insurers as well as physios, you know, who should we deliver care to via tele-rehab, which patients? And so safety is important, and we've currently got a PhD student who is working on an international core capability framework around delivering tele-rehab and coming up with a risk matrix that would allow you to say, look, this patient is, you know, probably quite suitable, this patient you'd need to reconsider. And it may be things around, you know, that they have a falls risk, you know, are they a very complex patient? So looking at the safety issues as well. Ongoing patient engagement and adherence can be an issue, as I already mentioned, particularly when there is you know, these automated services. Licensing and regulatory requirements. So you need to look and ensure that your health insurance, your practice insurance, your physio insurance covers you to deliver care remotely. So that's important. Are you're regulated to be able to deliver care in this manner, and that differs across countries and across states. Privacy and security, really important to ensure that the platform you're using is private and secure. And we've all probably heard about Zoom have now introduced some additional security measures because they had, you know, random pornography popping up on people's Zoom meetings and so forth. So privacy and security is a very big issue for the telehealth platform that you're using, and now there's some commercially available ones out there as well that you know, really pay attention to this. And then you need to, you know, some of the implementation issues. Well, if you're not being funded for it and patients have to pay for it out of pocket, that's an issue. So reimbursement and your fee model are also issues. So just some tips about what we've learnt, you know, in terms of planning. Choose your population carefully. Think about, are there any implications if I can't put my hands on or see that, you know, be there physically? Is there going to be any implications for my management? Assessment, if you're thinking about patients, and this is not necessarily people with OA, but if you're thinking about using it for any patients, you know, do you need to have diagnostic tests, and can you perform them remotely? If you're seeing someone that you've never seen before and they don't have a diagnosis, are you going to be able to assess them remotely? And there is certainly some evidence around the validity of remotely delivered assessment. Treatment, do you really need to do manual techniques? Because if you do, obviously, then that's not going to be easy to do unless you can get someone to help the patient. Maybe they can have a partner help with some manual techniques, but otherwise that could be a bit tricky. Do you need to have one face-to-face or a series of face-to-face consultations first? And then, as I said, safety and screening of patients. So what we do is we look at falls risk, and if patients are at falls risk, we get them to go and see their GP and get clearance from their GP. Same with if they've, for exercise and physical activity, if we get them to fill in an exercise screening form, and if they're deemed to be at risk again, they might need a clearance first from a medical practitioner just for covering you. Choose your mode of delivery, you know, telephone, video conferencing. Well, obviously the telephone is highly accessible, but you don't have that visual contact, but it may be that you need to use the telephone if the person doesn't have video conferencing, their internet's poor, or they can't access, you know, they're not good technologically to be able to use that. Video conferencing, again, as I said, patients may be unfamiliar with video conferencing, but we found that most people, when you give them some resources, they can, you know, just follow step by step and can troubleshoot and use the techniques and the technologies. Think about the setup instructions and the support for patients, and I've got some resources later that you could go and use with your patients. But, you know, making sure you get the patient's phone number so that if while you're doing the video consult there are any issues that they drop out or they collapse while you're speaking to them, you can ring someone or ring someone on, you know, an emergency contact, or you can phone them to speak to them. How you're going to manage your appointment systems, how you're going to take your notes and so forth. So all of those to think about. And as I mentioned before, it's really around setting expectations. And, you know, there really is this widely held belief that physio involves hands-on treatment. So educating patients and therapists about the expectations of tele-rehab and overcoming this skepticism. And I think also, you know, having brochures and pamphlets where you really introduce the service, give a photograph and a description of the therapist so people know who they're talking to can also really help. So I wanted to just make you aware of a free online training program that we have released for physiotherapists because of COVID. This is a training program for physios called the PEAK program, and it trains physios to deliver the PEAK program to manage knee osteoarthritis. The PEAK program is 5 physio consults with home exercise. There's patient digital resources, there's an exercise video website that you can use. All of this is for free. You can do the training and you can mix and match. You don't need to deliver the PEAK program. You can, pick and choose parts and just incorporate it into your practice. But as I said, this is a program that we're currently testing in a non-inferiority trial to see whether this program delivered remotely gives you the same outcomes as if you delivered the program face-to-face in your rooms. And we obviously had to put the trial on hold while we deal with the pandemic, but we thought we would release all of the resources and the training materials for physios. So go to that website and you can register and have a look. It probably takes about, I think people were taking about 4 hours to do the program. And we'd certainly value your feedback. There's a part that you can give some feedback at the end as well. The other program that I would encourage you to use for any of your patients who have chronic pain, not just knee osteoarthritis, but this is that pain coach one that we tested earlier that I mentioned the results of that study. Well, we've now taken it and renamed it and made it work on mobile devices and updated its look, made it a bit more modern. And it's called Pain Trainer. And again, if you go there, it's freely available for your patients and you can have a look at it as well. But it's that 8-week program that patients can work through. And I think it's very valuable for patients. Some people really like it, others are less into it, but I think it gives patients options. And you say to patients, I think a way of selling it is it's like a sort of a smorgasbord or a buffet lunch, where there's a whole range of different dishes that you can taste and see which ones you like, and you might not like the curry, but you really like the chicken or the vegetables. And so here, the patient learns different skills and they practice those skills, and they might find that they really like the relaxation, that really works for them, but the activity rest cycling didn't, for example. But again, to say to patients that they have to practice the skills for them to become effective. It's like riding a bike. You need to learn those skills for them to become effective and to see how they go. So again, please try that out and see what you think with your patients, and encourage them to try that out as well. So in summary, and we'll take then time for questions, but we can see that treatment of knee OA in particular is suited to remotely delivered physical therapy because of the emphasis on education and exercise and pain management. There is a relatively limited evidence base, but it really is promising. And we're showing that you can deliver this. It's acceptable to patients. It's acceptable to physiotherapists. It's effective. It improves pain. It improves function. And I think, though, that we still need more to work to look at how we can investigate and to overcome some of the practical issues and barriers to implementation. And I must admit, if COVID has shown anything, it has shown the real value in us needing to be able to provide care in this manner, and has shown the effectiveness of such care. So that could be one good thing that comes out of this, in being able to deliver care to people remotely and in rural regions as well. So I'd just like to acknowledge my fantastic staff and students at the Centre for Health, Exercise and Sports Medicine at the University of Melbourne, all of our funding bodies, and the patients and physios who have participated in our research over many years. And I will stop there and take questions. Thank you.
Well, thank you, Kim. I'd like to just remind our listeners that you can type your questions into the chat bar, and then as the moderator, I will then ask those questions on your behalf. So, Kim, the first question that we have is really, it's probably something that physiotherapists around the world and healthcare providers, for that matter, are feeling a bit overwhelmed at this current time, and especially when considering this kind of a delivery model. Do you have any suggestions on where do you begin in developing this type of a platform of delivery? Do you have any, maybe 3 main considerations of where to start?
That's a good question. It does depend on sort of your practice and where you are and so forth. But there are some commercially available platforms that might be a good place to start. And I know that they're, providing reduced rates, and I'm got no conflicts of interest. I'm not receiving any payments from any of them, so I'm not pushing any, but ones like CoView, COVIU, PhysiTrack, and others, they're out there, and I know that they're sort of helping to get people started. So that can be a good way, because they've got payment setups, they've got the appointment setups, and it's all sort of in one place, because that can be a bit difficult where you're trying to, how do you set up the meeting to the time for people and so forth. So, you can look at those. As I said, otherwise you can look at just using Zoom yourself, and you can invite the patient, and you can send an invite to them, and it's got the codes in it there. So I suppose that's one way, is looking at how you're going to set up what platform that you're going to use. Then I think it's a matter of looking at what conditions and services and so forth are you going to offer. Is it going to be everybody that you're going to try and do this? Is it going to be certain patients? And then it's sort of all the practical things, making sure you've got the setup. You want to have it looking professional. You don't want people to be looking in your living room and there's all people running around in the background. So again, it needs to be set up in a way that looks very professional, whether you're doing it in your rooms or if you're doing it from home, making it look professional. A lot of things like that. As I said, getting the person to give you their phone number at the start so that you could contact them if need be, or an emergency contact, talking them through how it's going to work, all of those things. And I think also, patients are probably learning a bit on the go as well. So it's, everyone's sort of learning together when it's people's first time, and I think people recognise that. But also there are people who have been ahead of the curve, and if we like, ahead of the curve, and have been using tele-rehab. Many of your colleagues and I have already been using that for quite a while. So using them as resources as well, if there's, there are people in your physio community that you could speak to. I know our association, the Australian Physio Association, have been helping. They've got a lot of resources. They've got a manual to help people. So again, your association may also have some resources like that. And I'm not sure whether IFOMPT may have some as well that can be made available, manuals that you can go to. As I said, if you do our training course, it's relevant not just for knee osteoarthritis, but it's got whole modules around delivering remotely delivered services and all the practical things that you need to think about in terms of your bandwidth and what to say to the patient, and turn off if you're having trouble, turn off your audio, your video, because just having the audio can help and so forth. So that's probably a long-winded answer to you to the question.
I think that's great. That definitely gives physiotherapists a couple of things to think about. The next question is with regards to the mode of delivery. Do you think that this works best in any specific type of patient? That is, my patient population is all upper quadrant or lower quadrant or spinal, or does it depend on the demographic, males versus females, older versus younger, educated versus uneducated?
Yes, that's a really good question. We had a look at, in our trials, whether there were any patient characteristics that moderated the outcomes. That is, were there patient subgroups who responded differently to the interventions? And we didn't find that to be the case. So, it didn't come out that the younger people did better than the older people, men, women, no. So I think that it doesn't actually matter. I think it more is around what you're trying to achieve with your intervention and your service. So I do know someone was asked us a question around, they're doing vestibular rehab, and they were saying that they were finding vestibular rehab quite difficult to do because they couldn't, I don't know a lot about vestibular rehab at all, but something around the eye movements, and it was quite difficult to do remotely, the assessment that they needed to do. So it may be that some patients that you've got, it is quite difficult to, depending on what you need to do for that particular condition. So, and I think you'll know your patients best around, really, can you deliver that care that you need to safely and effectively? And certainly chronic conditions, I think, where really your mainstay of treatment is exercise and education and pain coping strategies, that's ideally suited to being able to do care remotely.
Then the next question kind of builds on this, and it comes from our friends from Greece, and they're sort of inquiring about some of our patients have other comorbidities such as dementia, for example, or patients who cannot understand the exercise or the intervention. Do you have any recommendations on how to treat these patients with telerehabilitation or how to improve compliance?
Yeah, look, that's a very good question, and my answer to that would be practical. It comes from my experience. I've got a daughter who has special needs, and so we've been doing now tele-physio with her, and that requires someone else to be there. That requires me to be there because she obviously can't do, she's got limited IQ, so she can't. So it'd be the same as someone with dementia. They're not going to be able to set up and click on the the web link and do all that. They will need someone there with them, a carer, to do it. But you certainly can. So in my case, I can do that, and we talk through with the physio, and it shows what to do, and then I do it for her. So if that person has got a carer, then I think you can equally, like you would in, if you were there in person, you'd be getting someone. You can, again, if you can safely tell that person, that carer, that what to do, then I think you still should be able to do it remotely as well.
Great. Now, is in terms of the frequency of communication, is this different than face-to-face interventional models? That is, should you be communicating with them daily via text, email, calls on the telephone? Do you have any recommendations there?
Yeah, so we have been looking at a lot of our service delivery models are actually looking at care that doesn't require a lot of therapist input, because, as I said, we know that we need to come up with, as I said, models that the government, that we can roll out, that are scalable. It's not going to be scalable, and the government and the health insurers will withdraw these temporary rebates if they find that everyone's now being treated daily. So in fact, as you saw on our interventions, we were having 5 consults over 12 weeks or 6 consults over 6 months. So very much around empowering the patient to do it. And we were showing very good benefits from a limited number. And I think that really fits with a lot of healthcare systems where people aren't going to be able to afford to have lots and lots of visits. I know that in some Scandinavian countries, for example, they are doing 2 visits a week, but over here, that's not something that's going to be sustainable. If patients can afford that and pay for that, that's fine. But in terms of being able to be funded by governments and health insurers, that's not feasible. And we've had very good outcomes from a limited number of visits, because, again, what we do is we're teaching the patient the skills and then checking up. So what we do is we space them out so that they're a little bit more frequent to begin with, and then space out the time. So week 1, there's 1 in week 1, and then 1 in week 2, and then 1 in week 3. So for example, spread them out, but have a few more closer together at the beginning when you're trying to see how patients are going. Certainly, we've been also looking at the use of SMSs to help with adherence, and we've just finished a study. Rachel Nelligan, one of my PhD students, has just finished a study where she showed that an automated SMS service increased adherence to home exercise, and that service would cost someone $8, for a 6-month service. So there's some very cheap ways that you can help with adherence that don't require patients having to have more visits and increasing costs in that way.
That's great. Now we've got a few more questions, but unfortunately we're getting close to the end here. So maybe what we'll try to do is try to deliver some of these questions to Kim via email, and then be able to post some of those answers in the future. At this time, I'd like to thank Kim for taking the time out of her busy schedule to present such an amazing presentation today. I'd like to remind our listeners that today's session has been recorded, and you will receive information about certificates of attendance following this webinar. We continue to welcome any feedback from our listeners as well on the webinar and lecture series. And feedback can be provided at admin@ifompt.org. I'd like to thank all of the MOs and RIGs for your ongoing support. I'd like to remind you as well that the IFOMPT Congress in Melbourne has been postponed to September 19th to 21st, 2022. So please put those in your calendars. I'd like to remind you as well that our next speaker will be Michelle Sterling, and that is in early June, June 9th and 16th, and she will be speaking on early physiotherapy management of acute whiplash injury. How can we do this better? So once again, Kim, I'd like to thank you for this excellent presentation.
Thank you very much, and I hope that everyone, you and your loved ones, stay safe over this time. So thanks very much for listening.